Hi everybody, I'm Dr. Okolo-Taku, and this is a Lunch and Learn on CLL, or chronic lymphocytic leukemia. And I'm glad that you're here to join me today as we spend a little bit of time getting to know this disease profile. Okay, so I prepared some slides for you, which will be displayed on the screen as well, to show some important details about the disease. First, we'll get started. What is chronic lymphocytic leukemia, also called CLL? So before we get into the details, the first part of the presentation is going to be a definition. So kind of explaining in detail what the disease is and certain nuances about it and a different type of the disease as well. Then we're going to move on to symptoms, where I'll be describing kind of the more typical things that people experience when they get this diagnosis, as well as looking at some lab results and pathology results that help us diagnose it. Then we'll be looking at staging, and then the most important part for you, prognosis as well. So let's get started. Okay, so CLL versus SLL. CLL is a cancer that affects the white blood cells, specifically mature B cells, okay? So you'll be hearing that word a lot, that B cell leukemia or lymphoma. So we get abnormal clones of this mature B cell. What that means is that there's one aberrant cell that just starts replicating itself, and it basically takes over the entire system, and this starts to circulate in our body and disrupt normal functioning. And then there's another entity under the family of chronic lymphocytic leukemia, or CLL, called SLL. SLL stands for small lymphocytic lymphoma. It essentially is the same cell type as CLL. The difference, though, is that SLL is actually found in more of a solid formation, whereas CLL is a liquid formation. By that, what I mean is that SLL is usually found in our lymph nodes, and CLL is found in the bloodstream, just kind of flowing through. And like I mentioned, it has the same identical cell type as CLL, but is mostly characterized by lymph node involvement. So when the disease is primarily in the bloodstream, it is CLL, and when it is primarily in the lymph nodes, it's called SLL. So, demographics. Let's talk about who is affected. We've actually found that there is quite a big difference between who becomes affected by CLL, actually even based by region. We know that there are higher rates of CLL in the Western countries like US and UK, as opposed to countries in Asia like China, where we barely see this disease at all. So the most common leukemia in the US and in the Western Hemisphere is CLL. And it is more common in men compared to women. And more specifically, it affects older aged people than younger aged people. The average age of diagnosis for CLL is 70 years old. But although it is characterized as a cancer of older age, we have actually been seeing CLL in younger people as young as 30 years old. And like I mentioned, it is mostly seen in the Western Hemisphere. It is mostly seen in white Americans compared to African Americans or Asian Pacific Islanders. And the cause is postulated to be more of a genetic factor than environmental. We see that people with first generation relatives do tend to have a higher rate of developing this disease. So for example, if a mother or a father or a sister or brother has CLL, that person has a higher chance of also developing CLL compared to just general environmental exposure. But there is a caveat. We are seeing higher rates of CLL in military personnel, specifically those exposed to chemicals like Agent Orange. So that is one environmental factor that seems to have a pretty solid link to CLL. And like I mentioned, that familial predisposition among first-degree relatives as well. Moving on to symptoms. So CLL is actually mostly discovered incidentally. What that means is that one might be at their primary care physician's office getting their annual blood work, and it pops up with an abnormally high white blood cell count. And that's when you end up being sent to the oncologist for further evaluation. Sometimes people are diagnosed with lymphadenopathy. So you might feel lumps or bumps in your neck area, under the armpits or in the groin. You go to see your physician and they send you for evaluation. You may potentially get a biopsy. These lymph nodes, these swellings that kind of grow around this area, they tend to be painless, immobile, but bothersome, and that's how some people get diagnosed as well. And then a small percentage of people get diagnosed because they have what we call these classical B symptoms. So these B symptoms typically is what you would call when someone is having just kind of chronic low-grade fevers for 2 weeks consistently, drenching night sweats. So not just a little warm while you're sleeping, but almost as if you have to change your clothes in the middle of the night because you sweated so heavily. And then we can also sometimes see people get unintentional weight loss. So you're not exercising, you're not trying to, but the weight is just falling off. And so these are B symptoms, and a smaller percentage of people present in this manner and end up seeing their primary care physician and then get referred over to oncology. And even rarer still is some people get diagnosed when they have autoimmune hemolytic anemia. What that means is that the CLL cells start disrupting your body's normal functioning and your red blood cells start to destroy themselves. Your body almost doesn't recognize its own red blood cells, starts killing them off, and you end up becoming severely anemic. You may notice changes to the color of your urine. You may have skin changes like little rashes called petechiae. And so this is a very small number of people that get diagnosed this way. But for the most part, CLL ends up being diagnosed incidentally through an annual blood test that you may have with your primary care physician. And this should give you an idea that for the most part, this disease is something that doesn't really present itself in an aggressive manner. So, moving on to signs and symptoms. So I like to call this section lumps and bumps. Like I mentioned previously, some people present when they feel a lump around their neck, in their armpit, in their groin area. This is called lymphadenopathy, and that's enlarged lymph nodes. So that's one of the most classical signs of CLL. And in the most cases, this lymphadenopathy is going to be in the neck area, but for some people, it can present in the groin, in the axilla. And the classical sign for this lymphadenopathy is that for the most part, it's painless. It's rubbery, painless, freely mobile, except in situations where multiple lymph nodes kind of in the same area grow and kind of conglomerate together. Then it might become a little bit more painful, less mobile, things like that. Another sign and symptom is splenomegaly. What that means is that your spleen, which is an organ on the left side of your abdomen, can become enlarged. So some people will start to notice that their abdomen area is not as flat or smooth as it usually is, and they might feel a bump on that left side of their belly. That's usually the spleen when it becomes enlarged. On the other hand, someone can also present with hepatomegaly. What that means is that the liver can become enlarged, and the liver is on the right side of our belly, and one might start to feel a bump on that side as well. And then we can also see skin manifestation. We call this leukemia cutis, and I have a picture of this on the slide, so you can take a look at that. And that's when the CLL cells actually come to the surface of the skin and present with an abnormal looking rash. Again, that's called leukemia cutis. And these are kind of the main, most common presentations that we can see as far as signs for CLL. So again, that's lymphadenopathy, splenomegaly, hepatomegaly, or leukemia cutis. Let's look at the blood. So what do we see when we're looking at the blood of somebody who recently gets diagnosed with CLL? So we're going to be looking at lymphocytosis. These are the atypical cells that start to fill our bone marrow and our blood of these one clone that essentially, that aberrant cell that just starts going crazy. And I have a picture on the slide for you to take a look at that too. So this is what leads to the increased white blood cells. These cells that proliferate end up making our white blood cell counts jump super high. And so when a pathologist or your hematologist, oncologist looks under the microscope, these are the cell type that they're looking for. We also see something called smudge cells. A smudge cell is not an actual cell type. It's actually when the lymphocytes, when those cells have burst and kind of smudged on the slide that the pathologist or the hematologist, oncologist is looking at. And so those are kind of classic blood findings that we see under the microscope when diagnosing CLL. So, clarifying diagnosis. So, how do we diagnose the disease? We're looking for an absolute lymphocyte count of over 5,000. What that means is when we look at your complete blood count, your CBC, one component is called the WBC. That's your white blood cell count. That count is actually made up of several different types of white blood cells, including your lymphocytes. And so, we're calculating that and looking at lymphocytes, looking at a number being greater than 5,000. If that number is present, then we become suspicious that that person has CLL. But we also need chronicity. So not just you have one blood test that showed this increased cell count and then went back down. We're looking at increase in your white blood cell count, this lymphocyte count, for at least 3 months consistently. Then we move on to something called a flow cytometry. And the flow cytometry is a test that helps pathologists identify essentially the fingerprint of a cell type. And so if we see increased white blood cell counts, we see it there for consistently at least 3 months, we can do something called the flow cytometry, kind of fingerprint the cell type, make sure that it has the specific markers that identify it as these unusual CLL cells, and that essentially helps us diagnose it. For SLL, the white blood cell count might actually be normal. It may never go above that 5,000, but again, what we're looking for in that situation is the presence of that abnormal lymph nodes, so that lymphadenopathy. Finally, sometimes we have to do something called a bone marrow biopsy to diagnose this disease, but not always. A bone marrow biopsy is a procedure we do using a large needle, going in through the skin, through the bone, and extracting marrow from the bone. This is kind of where all of our blood cells are created, and helping us see how much the disease may have infiltrated the bone marrow and disrupt the promotion, the generation of regular normal blood cells. All right, so now we've kind of identified demographics, we know who's affected, we've looked at signs and symptoms, and we've briefly talked about how the disease is diagnosed. So now let's talk about complications, because unfortunately, as if the disease itself wasn't complex enough, now we also have to look out for certain entities that can present themselves and make the disease even more complicated to treat. So besides the very, very high white blood cell count, what this means is that if our white blood cell counts become very, very increased, they can actually start to encroach on the normal production of our other cell counts. And so when you have really, really high numbers of lymphocytes, you might end up getting lower numbers of your red blood cells, of your platelets, and your other white blood cells like your neutrophils. And essentially what that means is that you could become anemic. That's when the red blood cells are low. You can become thrombocytopenic, that's when your platelets are low, and you can become neutropenic. In neutropenia, that means that you become more susceptible to infections because our neutrophils are one of our white blood cells that help us fight infections. When somebody becomes thrombocytopenic, that's when our platelets are low. It can actually make us more susceptible to bleeding and bruising because our little platelets are actually what help our blood clot off normally if we get a cut or start to bleed. And then anemia, which a lot of people are familiar with, is when our red blood cells are low. And when we become anemic, some signs and symptoms that we might have can be fatigue and shortness of breath because our red blood cells are our oxygen carrying cells, and so when those numbers are low, you do start to feel the symptoms of almost not having enough air with the shortness of breath and with fatigue. So another thing that can happen, a complication, is hypogammaglobulinemia. What that means is that our immunoglobulins become very low. Our immunoglobulins, as the first part of the name says, immune, are our blood cells that help protect us. These are our immune cells. So when they're low, people might find that they're more susceptible to infections, bacterial infections, and this is something we can actually test for. So keep that in mind if you are diagnosed with CLL and find that you are becoming more susceptible to bacterial infections. Something that I mentioned earlier before is called autoimmune hemolytic anemia. Again, this is when these CLL cells make our body almost confused, unable to recognize its own self, and we start attacking our blood cells and become anemic, and this can actually be a medical emergency. So this is something that your oncologist will be looking out for. And then in some cases, CLL, which is typically known as not an aggressive type of B-cell leukemia, can transform into a more aggressive disease. This is called a Richter's transformation, and it can either transform into a diffuse large B-cell lymphoma and sometimes into a Hodgkin's lymphoma. So again, these are things that your oncologist will be looking out for during your treatment process. Moving on to staging. So staging in blood cancers is a little bit different from staging from solid cancers like breast cancer, prostate cancer, because the blood essentially flows throughout your body, but we do have specific ways to characterize and stage CLL, and of course staging is a way that we use to identify aggressiveness and also helps us determine the prognosis of a person with CLL. We use two systems. One is called the Rye and one is called the Binet stage. Essentially, it's looking at both physical symptoms as well as lab findings. So this can be the B symptoms that we talked about. So we stratify into low, intermediate, and high risk using the Rye and the Binet staging system. For somebody who has just elevated white blood cells, this puts them at a Rye stage 0. But when the person has increased white blood cells, they have increased or the presence of lymphadenopathy, they have enlarged spleen, enlarged liver, and then we start to see lowering blood counts like red blood cells and lower platelets. The more of these findings that accumulate, the increased risk and the higher the stage. Additionally, with the Binet system, we're looking primarily at nodal involvement. So do you have enlarged lymph nodes in the neck, in just that area, or do you have enlarged lymph nodes in several parts of the body? And this can be internally as well. So in our abdomen, in our pelvic region, and the more areas that are affected, the higher the risk and the higher the stage. Okay, we're almost done. So we've covered staging, now prognosis. The importance of staging, again, is to help us determine prognosis. Typically, the survival time for CLL is pretty heterogeneous. What that means is that it's not just a small number. It can range from 2-year survival to 20-year survival, depending on when the person is diagnosed and the stage at which they are diagnosed. But the average survival is probably around 10 years. We use something called the International Prognostic Index to help us determine a person's average survival based on their stage and how aggressive the disease may be at presentation. So I have it here on the slide, kind of showing how a person can accumulate points. The more points a person accumulates as far as the disease, the worse the prognosis is. So typically people who are diagnosed at age 65 or older, people who have the classical Binet or Rise staging B or C, that means higher stage, have a worse prognosis. We do a blood test called a beta-2 microglobulin. If that number is greater than 3.5, you get 2 points as well. When we're looking at your flow cytometry, these are lab tests, and your FISH, we're looking for something called IGHV mutation. Somebody who is unmutated has 2 points. And then we're looking for something else called TP53 or a 17p deletion. And this is a big one. Someone whose cell types have this finding actually gets 4 points in their when we're calculating prognosis. So for somebody who is low risk, say you only have risk factor being your age, you're greater than 65 years old. Someone with low risk, their 5-year survival is actually 93%. What that means is that 93% of people who are diagnosed and who are low risk will still be alive 5 years later. If you are intermediate risk, your 5-year survival is 79%. If you're high risk, your 5-year survival is 63%. And if you are very high risk, meaning you have that TP53, IGHV mutation, unmutated, you're very high risk, and unfortunately that 5-year survival goes down to about 23%. So prognosis can vary a large range, and that's why for some people survival is as high as 20 years, and for some people survival is as low as 2 years. So let's talk a little bit about treatment. There are many drugs out there that are great now for CLL. I'm not going to go into details for that. What I want to discuss is who do we treat, why, and when. Because CLL is usually diagnosed incidentally from a complete blood count, not everybody needs treatment immediately once they're diagnosed, because you might just have gone in to see your PCP and get blood work done and this was discovered. You're not feeling poorly, you feel exactly as you usually did. So it does not help you for us to start treating you at this point unless there are certain findings that we consider to be high risk factors. So as far as when we start treating, I have a slide showing certain criteria that helps us determine this. So marrow failure, what this means is, are we starting to see that these cells are just so rampant throughout your body that they're disrupting your bone marrow's ability to make your other cells? So you're becoming anemic, thrombocytopenic, you're becoming at risk for infections. So when we start to see that, that's one indication for us to start treatment. Another is splenomegaly, like I said, that organ on the left side of your abdomen. If that starts to get enlarged, that could be at risk because it can actually end up bursting, to put it quite frankly. And so we want to decrease the size of the spleen, and the only way we can do that is to give you medication for that. Massive lymphadenopathy is another criteria. So if the lymph nodes start to grow really large, pushing on certain organs, pushing on the heart, pushing on the airway, obviously we don't want that to go unchecked. We would start treating you. Lymphocytosis, so this is the actual white blood cell count that we see. Some people's white blood cell counts could be as low as 5,000, like I mentioned, but there are some people who can have white blood cell counts in the 100,000s, 150,000. That alone itself is not an indication for treatment, but if it becomes high enough that it does start to disrupt functioning, normal body function, normal cell functioning, it would be an indication for treatment. And then the autoimmune problems, like I mentioned before, if our body stops recognizing our cell types as our own and starts attacking it, that would be an indication for treatment. So these are more of the signs that we would look out for, but we do also treat for symptoms. So if you come in, although your lab work looks perfect, but you're saying, I just have overwhelming fatigue, I do not feel well, I am having constant fevers, I am soaking every night, the night sweats are just so intense, I've lost so much weight, we would treat you. So there's not a specific cell number that we look for when we're treating, but we kind of use all these findings, both the signs and the symptoms, to help us determine who to treat and when. Alrighty, so I hope you learned a little something about CLL. There's a lot of information that was covered, but even more information that I didn't cover because it starts to get a little more complex. But hopefully this was bite-sized and digestible enough. And of course, if you have any additional questions, please do not hesitate to reach out to our offices, get in touch with your oncologist, and we'll be happy to talk with you in more detail. If you liked this video, make sure to check out our other videos here on our YouTube channel, videos with me and of course of my colleagues here at Ironwood Cancer Research Centers. And we also have our Instagram page and new TikTok as well. So a wealth of information is out there for you, and make sure you check it out. Thank you.